Hello, everyone, and welcome. My name is Professor Chris Bain, the lead for the ADAM Alliance at Monash Uni. It's great to have you all online with us today. I'm expecting as I start speaking now, our numbers will build up as well. I am really excited to be talking with you today about our latest ADAM deep dive topic, which is digital twins. And we've postulated the question, are they twice the value? So is having a replica of something about a human being represent twice the value over the baseline state? Really excited for the speaking panel we have today. Some of you may have seen some early advertising, and one of our speakers unfortunately needed to pull out last minute, so I'll be doing the first speaking slot today after this introduction as well, but our remaining three speakers are just as advertised. Firstly, I would like to respectfully acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional owners of the land on which I'm sitting today. And I'd like to pay my respects to their elders, past, present, and emerging. So for those of you who haven't been on these sessions before, just a little bit about Monash University. Firstly, Monash, by student volume, is in either the largest or the second largest university in the country. And I know some of you are from Victoria, some of you from Australia, and some of you from overseas. We have a large presence at multiple sites in our state of Victoria. We have a campus, a standalone campus in Malaysia, including representation of our Faculty of IT over there. We have a new campus in Indonesia. We have a facility in Prato in Italy, an alliance with Warwick in the UK, and our Faculty of IT that I work in and I'm based from has links with Harbin University in the north of China, with Southeast University in Nanjing, and also with the IITB Monash Academy through IITB Mumbai. And they also now have a new centre called the Koita Centre for Digital Health, and we may even have some of our Koita colleagues on the line today. We run our digital health program from the faculty, reaching out into the rest of the uni, into the healthcare system in Australia and into global areas as well through our Alliance for Digital Health, or ADAM. You can see on the right there are many, many different departments and schools inside the university, but also many regional hospitals around our area and small and medium enterprises, both in Australia and Southeast Asia, who are part of ADAM. And through these organisations, we have over 400 people with an interest in digital health collaborating with us in different ways. So these sessions showcase some of the work going on through different topic lenses across our ADAM members and partners. You can see here the different topic lenses we use for ADAM work. We've already had a session this year on EMR optimization on the left side there. And our first one was on forensic informatics at the bottom left. And today is on extended reality for health, with the topic being framed particularly around the idea of digital twins. I expect if you don't know what digital twins are, you will walk away much more informed and hopefully quite excited by what you hear today from across our speakers' experiences. We've also recently started a lab. Obviously, there's dozens, if not hundreds, of labs at an organisation the size of Monash. We think this is the only large-scale dedicated medical AI lab, and I've been lucky enough to be asked to be co-director of that with Associate Professor Zhongwan Gi. Digital twins is one of the topics we're picking up there, aside from the more sort of clear-cut examples of AI. So digital twins is one of those things where AI might be brought to bear, but also a lot of different kinds of visualization, simulation, computational modeling, and so forth are relevant, as is various kinds of extended reality. So our speakers today, in order after I kick things off, are Associate Professor Ram Nataraja. Ram is a consultant paediatric and neonatal surgeon at Monash Children's Hospital here in Melbourne, and obviously has a Monash University affiliation as well. He has expertise both in the clinical and educational realms, and he is an expert in surgical simulation and technologies for surgical care delivery. Adjunct Clinical Professor Tan Phan is our second speaker, and Professor Fan runs a comprehensive stroke, young stroke, TIA, and minor stroke outpatient service. He's actively involved in the teaching of advanced physician trainees in both neurology and stroke at Monash Health, and he's leader of the acute stroke data mining and imaging division of the STAR group in the Monash University School of Clinical Sciences based at Monash Health. Last but not least is Dr. Andrew Stevens. Andrew is a research fellow in the Department of Mechanical and Aerospace Engineering at Monash Uni. And he's an electronic and computer engineer by training. And after completing a PhD in the control of artificial heart devices, he went on to work in biomedical engineering. Andrew, with Professor Sean Gregory, is currently now embedded in the Victorian Heart Hospital through the Victorian Heart Institute. So they do their research on site there. And his current research focuses on improving mechanical cardiorespiratory support for critically ill people. I'm really excited to see Andrew's presentation as we have a staff member working on that topic as well. So if you have any questions or queries for our speakers after today's event, I'm just going to leave this up here for a minute for you. You can contact me. It's easier than trying to remember 4 or 5 different email addresses. Just chris.a.bain@monash.edu. The A is very important because there is another Chris Bain at Monash, and I'll be keen to answer your emails. He may not be as keen to answer them through no malice. So just chris.a.bain@monash.edu. So on to our first talk. Now, just a reminder for everybody, there's a Q&A function that audience members can use to pose questions at any time through the webinar over the next hour and a half, hour and 3/4. We'll have 4 20-minute talks and then time for a panel conversation at the end. And please, if you have a specific question for somebody, make that quite clear in how you frame your question, but otherwise we'll pick up more generic questions as we go through and also discuss some of those in our panel section at the end. Okay, so in my talk, I'm going to give you a sense of evolution of digital twins and how in some ways the concepts aren't actually new at all, but some more modern technologies really make this area quite exciting these days. And I'd really like to acknowledge that some of the work I'm showing is actually the work of PhD students, some of whom I'm involved with, others I'm not, but very supportive of, and in particular Vahid Paul Youssef and Kabir Rufai and their supervisors who are doing some very interesting work. But what I'm going to start with here is actually some of my own work. And as you'll see, if you can read that publication date up the top there, that is now about 12 years ago. And this work is in the space of hospital management and in particular patient flow management. So trying to deal with issues of supply and demand in how hospitals configure their services, be that in an operational sense or more likely in a strategic planning sense. And so to the right here is a screenshot from a web page wrapped around a discrete event simulation product called Simulate. And we were doing a lot of work at this time. That was at the end of about 5 years of working on these kinds of problems. There was a period in our own health system in Victoria where hospital admission reduction programs were running and hospital demand management was a particularly hot topic. It's not gone away as a topic, but there was a lot of work going on about computational modelling. So in this case, this is, if you like, a digital twin of a ward or a hospital or a series of wards, depending on how you configure them, rather than a digital twin of a patient. But this idea of can we digitally replicate something, well, in many ways it's been going on for years. People have been building models, initially even anatomical models or scientific models, but increasingly computational models of how human beings work or parts of them work for a long time. But I think this quote from about 7 years ago from the then CEO of GE Digital really sort of encapsulated a paradigm shift that's going to be facilitated by things like AI and machine learning, but also really cutting edge digitalization tools and techniques and extended reality as a paradigm. So that CEO predicted that we will have a digital twin at birth, and it will take data off the sensors everybody is running, and that digital twin will predict things, or more likely enable prediction of things for us about disease and cancer and other things. So in that setting, a digital twin could inform tailored treatments for a patient and predict how their individual disease might develop. It could even be used to trial potential treatments rather than testing them on the patient. Testing is probably too strong a word, but these sort of notions align very well with the idea of personalised medicine. And rather than giving somebody the drug because it works in 70% of people like them, can we be sure that they're not in the 30% or even the really rare 5% where they'll respond very badly to it? You can see how those worlds of computation and personalisation may line up through digital twin. So in terms of digital twins relevant to humans, they could represent the anatomy of the human, the physiology, their biomechanics, the structure and function of particular organs or groups of organs, pathology in the human, procedures to be done on the human, response to therapy. I think this is a really interesting and complicated spaces like intensive care units, in cancer therapy, in people with multiple chronic diseases. Or digital twins could even be combinations of these things. There's obviously no limit really from a computation point of view. The limitation is what's meaningful, what has effect. Is there enough volume of need for something to happen? So computation is very good when we have a single big complex problem to solve, or if we have a less complex problem that needs to be solved over and over. And how does that overlay to all the things we could, in theory, do regarding digital twins in people? So, and apologies to some of you who may have seen some of this before, but I am going to talk briefly about the virtual autopsy work being done with our partners at the Victorian Institute of Forensic Medicine. In particular, the supervisors there are Professor Tim Dwyer from the Faculty of IT, Dr. Max Corday, who was formerly of our faculty, and Associate Professor Richard Bassett from the Victorian Institute of Forensic Medicine and the Department of Forensic Medicine. This is particularly important, and you'll see this in the next few slides, because of the work this institute does. It is a very unique institute in Australia. There are not many institutes like this in the world. And effectively, this is the scientific and R&D arm, if you like, of the State Coronial Service. If you compare to the US, for instance, often coronial services are run on a county basis or a city basis, not at a statewide or a national level. And one of the things this institute has done is for many years now, it has had a CT scanner, and certainly for the deceased patients they deal with, they also deal with living patients who are victims of crime, for instance. But the deceased patients all receive a CT scan, a full body CT scan, as soon as they come into the institute. And that CT scan has enabled a change in the autopsy rates for patients. Autopsies are very important to be done in certain circumstances, but social acceptability for them is changing. In some cultural groups, they are somewhat problematic. And there are a number of other issues about the long-term future of physical autopsies. So this is Vahid's work, and you get a sense of it here. This is an augmented reality display overlaid on the lab that Vahid is working in. And you can see there half of a body, and I'll talk more about what you're actually seeing there in a minute. You can also see displays of CT scans up in an augmented reality space and different views, basically of the same set of CT images, a transected view, but also an upright standing view. And of course, the patient isn't standing because they're deceased. But you can see how you can begin to explore that. He also has a made-up medical report floating in the virtual space to the right of the viewpoint there. And this is important. There are many, many pieces of information that need to be brought to bear in the decision-making of a forensic pathologist. Sometimes police reports, as well as all the internal information that they generate in the institute, sometimes medical records, and it's quite a lot of information to integrate. The centerpiece of this exploratory application, though, is the CT scan. So as I say, there are now about 100,000 full body CT scans under the custodianship of VIFM, and they can be used for research. There is a strong ethical framework and a research ethics committee, both at the Institute and at Monash University, that oversees this work. And what you'll see, the real part of what you're seeing there is the CT image at the bottom. What appears to be a person's body is actually a computational reconstruction based on the CT scan. So this person in reality may have quite different coloured skin, may be a little thinner or so forth. But don't feel like this is actually a person you're viewing, because it's definitely not. But you can see how in a virtual space you can start to do an examination based on the information in the CT scan. Other things that are possible is this sense of a virtual dissection, and I deliberately have left this. Has obviously been done in Vahid's room, so it can be overlaid into any space, because it's a virtual image, if you like, an augmented reality image over a physical space. And he's created here a box type function, so you can effectively have a sharp edge on one side of it and slide that up and down the length of the reconstructed person to examine what's going on in different layers. And you can strip away layers. So here he's drilled in, but he's only looking at the skeletal components of the CT scan, and has stripped away all the organs and the skin and so forth. And this is the insertion of an avatar into this space. So here somebody's acting in a completely virtual space through an avatar, doing, if you like, a virtual autopsy on the body in the middle, whilst also viewing CT scans at the top and those medical reports at the right. And the other thing, of course, is increasingly we're able to get digital pathology images where there has been already a physical autopsy, overlay and create a picture of everything going on. The point of the virtual autopsy, though, would be to avoid, other than really selective tissue samples being taken, to avoid large-scale dissection of the body. So why might this be useful? And I clearly have underlined the word potential here. We're not operating in this environment in a sense of, wow, this will solve all the world's problems. This is very exploratory. It's a research environment, but we think it holds great promise. So like in many really specialised areas in healthcare, a lot of the forensic pathology workforce is ageing. There's not many people going into training. There's not many places you can be trained. There's this question of, can this improve the speed and efficiency of an autopsy process without going to a full physical autopsy? So my colleague Richard Bassett was himself involved in victim identification in the tsunami back in 2004. He was in an area which had 5,000 deceased people to examine, bearing in mind that they haven't all died in the tsunami. Some people have used the tsunami to cover crimes, for instance. So it's very important that each victim is given every respect and every effort is made to truly understand how they died. If we look at the New Zealand mosque shootings from a couple of years ago, there's an expectation in some faiths of a really rapid burial. And if you have 50 people to determine a really legally binding cause of death on, that's very hard to do rapidly through traditional autopsy. Social acceptability for autopsy is lessening over time. This kind of system could enhance people's training more quickly. They could be trained on virtual autopsies just as we train, and you might see a bit from Ram in his talk, we train surgeons in virtual environments. The work going on at VIFM is incredibly specialised. There's only a handful of places in the world capable of doing that work. So if a remote organisation on the other side of the world could have a virtual system, then people can view those images across the internet and actually assist in consulting on specialised cases. When we look at all the other electronic pieces of information that I've alluded to, can the framework of a virtual autopsy be then used to leverage all of that fully? so that can all be brought into a digital environment, be it a desktop or a augmented environment or a virtual environment. And can we also then leverage the other more advanced things going on? So we've had another project, and there are quite a number of these projects with our partners looking at AI diagnosis of pericardial fluid. So can you tell if it's fluid in the sac around the heart or blood in the sac around the heart? And can you tell if it was a major contributor to death and also what caused it? If you can do some of those things with AI, again, bringing them into this computationally driven digital environment, that might also have an augmentative effect. And MRI can have a play in this place too. So this is on the horizon for our partners at Newton. So what I've done there is just try and drill down on one of the examples of a digital twin being worked on at Monash, and a digital process as well to use that digital twin. And that's just one of our pieces of work, but it's a really interesting and quite unique piece of work. I'm going now to talk about one that you might even be able to relate to a little more. And I should mention here, this has been heavily the brainchild of Dr. Peter Chan, who's an intensive care specialist at Eastern Health and one of our partners. And the work here is by Kabir Rufai, with Barrett Enns as his supervisor and myself supervising. And the idea here came from some of the trials and tribulations in the COVID pandemic. So you can imagine in the COVID pandemic, especially in an environment like an intensive care unit, but not only, even for the staff to be able to go in and sit with a patient and examine a patient, there was quite a lengthy process of them having to put on PPE or personal protective equipment. So gowns and masks of various kinds, visors, gloves, and then to have to take them off as well as soon as they've seen the patient and they leave the room. So PPE was a really interesting change en masse for the healthcare system. And this study I'm showing you here highlights that this is a meta-analysis of the impact of having to constantly use PPE on healthcare workers. And this was true all around the world. These people noted that personal protective equipment, PPE, use causes adverse events amongst healthcare workers. The most frequent adverse events are headache, dry skin, and dyspnea or shortness of breath. And several risk factors increase the likelihood of those adverse events. Importantly, noting that working conditions should be changed to decrease adverse events. So there's something of the spirit of that in this project. And this project is trying to build a digital twin of a critically ill patient. And what you're seeing here is our PhD student, Kabir, pretending to be a critically ill patient. Obviously, in the real world, the person would be connected up to monitors and would have sources of electronic data that you don't have in all parts of the health system. But here, these various cameras and sensors are capturing things about Kabir in a non-invasive fashion, so temperature and heart rate and respiratory rate, to try and pull those then into a digital twin of Kabir, which can be examined from outside of the theoretical room. So as you can see here, parts of what would be an ultimate solution show how a digital or a skeletal digital twin of him mirrors his real world movements, and that the sensors overlaying him are picking up his heart rate and his breathing rate. To the left, he has some pathology results, which would have come in from a pathology system. To the right, he has various medical reports and scans that would have come in from the relevant system. But the idea here is that you could be accessing all this information about the patient from outside of the cubicle. You don't need to physically enter the room. That's the really important thing here. That also has, and I'll show in a minute, applicability in other use cases as well. But very complicated work and very challenging work, and Kabir is right in the middle of working through this currently. And this is the kind of end game, I guess, this is from a slide from the medical futurist who's very prominent on social media. This is one of the very few times I use futurism in these talks, but this slide is valuable. You get a sense of how various different parts of the human body at a point in time might be brought to bear on a large screen, on a transparent glass outside the patient's room, on a heads-up display, onto all sorts of things, so the patient can be monitored in detail without being physically touched. Interestingly, down to the bottom right there, you can see various waveforms. So some of you may not be aware that we can already capture heart sounds digitally, we can capture breath sounds digitally. So if you add up all the things you can capture about a patient digitally, you can see how with the right work and environment, these can be brought into a digital twin of the patient. We get a lot of information about the patient without actually having to touch them. I'm not suggesting that's always a good thing to do, but there are times where it might be very valuable. So if we think about not just a critically ill patient, but what's called an immunocompromised patient. So somebody, for instance, who has cancer and is getting really low immunity from their treatment, somebody who has just had a bone marrow transplant. There's all sorts of reasons why we put certain patients in highly clean environments and allow minimal contact with them, aside from the fact that they're infected themselves. Reduced infection transmission, so that's a two-way thing. So patients don't catch infections off the staff and staff don't catch infections off the patient. But when you think about the time taken to put on all that personal protective equipment in the busy doctor or nurse's day, there's a speed issue, takes up extra time that might be used on seeing other patients. And it's also more sustainable environmentally if you're not generating all that plastic waste. Little question mark there, though, because we know some computational environments chew a lot of energy as well. So I'm not making a simple statement there. We need to think about that. Can this kind of thing be used to facilitate expert review? So we already have telehealth type solutions from a peripheral emergency department in the country or peripheral intensive care department into a central city department with more skills and experience. But we're saying, can this be more than that? Can this be true digital twin creation so that people can access all of the digital twin remotely? And there's also this idea of, can it reduce the burden on staff? Can they go into the room once a day versus 3 times per shift? And what does that mean for staffing needs? We know the health system's under pressure for staff, but there's lots of considerations in making that statement. As I say at the bottom, these things may also represent potential compromises in patients' care, including in the thoroughness of a review. One of the first things you're taught in medical school is to look at the patient and listen to the patient. So we have to be conscious that there might be things we miss if we're doing all of this remotely. We've got some, again, a little bit more futurism, but people are talking about this guy. I don't mind some of the work he does, Arthur Olesh. He created a vision, if you like, of how in the metaverse going forward, you would see a virtual doctor and the doctor would look at a virtual you. And the virtual you is a digital twin of you made by all your relevant data. Interesting idea. Not sure it will come to pass, but in terms of thinking about where things could go, it's not a bad image to have in one's mind. I'm certainly not going to stand here and say we're going to get there or that it's a really good thing if we do, but it's an interesting thought for those of us working in this space. Something a bit more realistic, though. So this is actually from Dassault Systems, or heavily sponsored by Dassault Systems, called the Living Heart Project. And so this is really bringing a digital twin to life in an operational sense. The technology companies, various researchers, educators have been working on this collaborative model so that they can make highly accurate, personalised digital human heart models so that they can look at cardiovascular medicine in silico. So this idea of testing a treatment or following the prognosis of a condition on the digital twin before they do anything on the patient, which I think is really interesting. And there are other real world examples like this. This is just one that people could relate to fairly easily. So with that, I'm conscious I have probably used my time. I have. So we won't pause for questions now, although I'll keep an eye out in chat. If anyone does have any questions, please use that Q&A function so we can see any questions you have. With that now, I'm going to hand over to Associate Professor Ram Nataraja for his talk. So thank you, Ram.
Thank you very much, Chris. That was fascinating, and I learned a lot from that as well. I think the world that we live in is changing, and I think that's why these kind of things are great. So I'm taking a bit of a left field view here, and I'm going to look at digital twins from a technology applications viewpoint in terms of my world, which is simulation-based education, surgical education, and also global health. So my name's Ram, and I'm the director of Monash Children's Simulation and also consultant in surgical education at the WHO, and also my day job as a pediatric surgeon and a general pediatric surgeon as well. So before we go on, I'd just like to acknowledge traditional owners of the land where we're all gathered here in our respective places. For me, it's the Wurundjeri people of the Kulin Nation on the lands where I both live and work. And I'd like to acknowledge and extend my respects to their elders, past, present, and emerging as well. So I'm going to do a bit of an overview here in the 20 minutes that we have to first of all define what is surgical simulation-based education. The more I do work with Simulation Australia, who's a very large organisation for simulation, the more I realise that simulation means different things to different people and different groups of people depending on your craft speciality, be that engineering, IT, or even traffic management and Army and Navy as well. Talk a bit about the evolution of surgical training and why this is relevant, and get the why do we need technology, why do we need innovation, why do we need advances. Some of the applications of mixed reality into my world of simulation-based education, and then thinking a bit about wearable technology advances for global health, which is an increasing big issue. So what is surgical simulation? So for me, it's the acquisition of essential core technical and cognitive skills in a safe, controlled learning environment prior to patient contact, hence ensuring patient safety and clinician preparedness. Now, this is essential. So we're creating a learning environment that is safe and is separate from the patient. So very much along the lines of a digital twin. So what is it to me? So this is when I first started more than 20 years ago, made a very low cost model with my team at Great Ormond Street. It had ovals onto it, a water-filled glove, very low cost, but we validated it. But that validation was done in theatre, and you can see the old monitor there. I had to beg, borrow and steal equipment to do it out of hours, and on the pain of death that if the equipment broke, then they wouldn't be able to do the operations the next day. So that's really changed, but technology's advanced, and that's why we're having these kind of webinars to really explore how it is advanced. And this is the new benchtops that do exactly the same job as what I used 20 odd years ago. So what are the modalities of this? So these are things that you've seen, so bench trainers, or mannequins that we use, and you may have encountered them in different forms, and we'll dive a bit more into that in this talk. Scenario-based, where we then use a mannequin, actually run through emergencies. Screen-based learning, and that's something that's becoming increasingly prevalent throughout COVID and the changes in the way that we deliver education. Hybrid. Now, hybrid I'm going to talk a bit about, but in terms of virtual hybridism, in terms of simulation-based education. But here you can see you've got a laceration that's then put onto a patient. So not only do the students have to suture the laceration and clean it on the model, they then have to speak to the patient as well. And cognitive skills is important as well. We talk very much that higher end thinking and cognitive skills development, which is vital for patient outcomes. And then obviously why we're here today, virtual reality, augmented reality and mixed reality as well, with the HoloLens, which is the primary headset that we're using at the moment. And then sim-based patients, where we actually have a trained professional who then acts as a patient and is giving that real high-end immersive feeling to consultation. But what is it to me? So this is actually Maurizio, one of my colleagues, and this is when we're doing a rural workshop. And this is what we did, and certainly this is where it's really, I show this picture, one for to illustrate what is surgical simulation, but this is what we used to do. We used to go out and do workshops in various places. So this is a trauma workshop to students in Bairnsdale, which is about 3.5 hours outside of Melbourne. And you can see the reaction from the students there. And this is an intraosseous needle insertion. It's where you put a little cannula into the bone of the baby or child and actually allow resuscitation through it. Now, this is quite a confronting procedure, very confronting in the fact that it's something that is really difficult to do, but also quite confronting in the fact that you actually have to drill through the bone of a baby to put it into their bone marrow. And these reactions from the students, excuse me, I want them to have in this environment, in a safe environment, not when every second counts when you're resuscitating a baby. And we're using these, which is our simulator that we use. And it's actually a crunchy bar wrapped in elastoplast, but it's very good fidelity for the procedure. And how has surgical training evolved? So this chap is William Halstead. He is, you might not have heard of him, but he basically revolutionized training at the time. And he was one of the founding fathers of the Johns Hopkins Institute in America. And he revolutionized surgical training and came up with an expression which I'm sure some of you will be very familiar with, which is see one, do one, teach one. Now, that's how surgery was built, but it came from a time where William Halstead also basically promoted using anesthetics for patients, wearing clean gloves and sterile gloves. To not wear your aprons that were blood splattered to take between patients, and also antibiotics and other things that we now take for granted, like using antiseptic solution for operative interventions. So we're changing this and we've gone to a competency-based model. But how do we train surgeons? We do train surgeons in this environment. So we do operate, we do let them have experience, and nothing will replace that because that's the higher end. However, what we can do is actually mean that patients are safe in the fact that they can gain all the skills that they need or can gain in a simulated or virtual environment beforehand. And this is what we do at Monash Children's Sim. So these are the laparoscopic simulators that we set up. But again, the old model of getting people into the center, getting them to actually pair up and then actually use the equipment in the center to then acquire these skills. So a step away from the clinical setting, but only a step that's not very far. And we also have done training courses for many years, and these are the cognitive ward rounds. You can see the bench trainers there, but also about orientation into theatre environments as well. But we teach laparoscopic simulation in these, and those are the bench trainers that you saw. These are low-cost things like putting a cap across, threading a lace through some pegs, untangling the paper clips, and also doing the glove model you saw, and stacking dies. But why do we do this? Because there are various skill sets that you use in laparoscopic surgery that you don't use in open surgery. And actually, these can be picked up in a safe environment before they go to the actual patient themselves. Now, COVID changed a lot of things, and it changed our paradigm as well. And we flipped our whole courses online. And the reason why we did this is, one, because of Zoom technology, we're talking on that today, and people could go there, but we sent out simulators to people's houses. So they actually had their own for continued learning there actually within their own environment. And we've actually trained up people in, there's probably more of those now, but in every state in Australia. So that is from our centre in Melbourne, actually to all of the states in Australia. We've been training surgical trainees since 2001. Now, how is this possible? So this is only possible with digital evolution and in terms of actually new technology. So we have online curriculums, we have feedback mechanisms, but more importantly, and one of the things that actually, rather than just me as the surgeon assessing them, I also get metrics. Now, this is very important where technology is expanding. So not only am I getting the subjective thing of actually watching a student operate or a surgical trainee, what I'm also getting is the objective measures. But these objective measures can also be used as terms of system-generated feedback for getting the students for self-directed learning. So it's not just me giving them comments to help guide them and really finesse their procedure, but it's also the fact that I can say, look, if you look here, the handedness is actually 2/3 to your left, 1/3 to your right. So you need to get 50-50 for this task. You know, all of these things are moving together where technology is expanding, where with these system generated feedback can really tailor the experience of our students. And these are two feedback things here. And I think this is really, as an educator, really shows what we need to do in terms of actually training. So you can see that they're practicing with instruments in a safe, non-judgmental zone, so they can finally start to do more in theatre and taken more seriously by my seniors. The second one, as I've been nice the whole time the course has been running, theatre access has been very hit and miss. The course has been my theatre practice whenever I had time. It's been a good substitute for being in the operating theatre. It's a great tool to keep your skills going, and I haven't felt like I lost any skills. And it may come to the point, and these are one of our models that we created. You've got the bow there, you've got the liver, you've got the thigh pyloric stenosis, you've got a baby you can put ports into, and you can see that we're actually operating on this baby as you would do a normal baby. And it may get to the point that these kind of twins, so this is not a digital twin, but we then send it out to our trainees who practice at home, and then we use that software, we use that motion tracking, we use the different levels to actually then guide the feedback that we give them. So how are we using mixed reality into this world? We haven't talked too much about it, but we have been using HoloLens at MCS for quite a few years now. And this is us looking at a hologram that's obviously projected in terms of us. Very good. I won't delve into it, but learning anatomy, doing all those kind of things, fantastic resource. There's also simulated participants and patients as well. And that's where you have a patient sitting in a chair who you can interact with. Again, a digital twin and something that we are starting to use, but it still needs to be finessed more. And that's where once you put the HoloLens on, you have the heart appearing with you, you have a patient sitting in front of you, and you can then interact with them. But what do we do, say, for the labour ward in Monash University? So you have this simulated baby in a birth canal here, and a very happy-looking baby. They're always very happy in our world as mannequins. And we devised workshops. So you can see this mannequin is being used with then a simulated participant who then acts as the mother, and then actually they then have to deliver the child. And this is where it goes into a simulated training environment where we're then assessing the doctors, we're recording it, we're using video debriefing, and we're really coming to grips. And one of the things we're going to be starting to use is actually eye tracking to actually see where they're looking in these kind of environments. So that's what we do at the moment. And I'm going to show a video just because it's far greater than what I can actually create in our own work, because it's an illustration of where we're heading in our center. So you have the same mannequin here, but you can see that they're actually looking, and this is from CEA Healthcare, they're looking at how the baby is. So this is where you then can actually see the hologram makes it much more immersive. You understand more, but more importantly, it's got the hips, and you can see how the hips change as the legs position changes. As the baby's pulling, you can see there's a neck force indicator, there's shoulder dystonia. It's giving you system is generating feedback and enhancing that experience. So this really gets the learner much more engaged within it. And this is where we can use mixed reality to really augment our learning experience, not just the reality that we see as well. And one of the steps we've done, and this is the first preliminary study that we've done, is the motor. So it's a motion tracking in the operating room. We took simulated tasks, operative tasks, taking the essential skills, so suturing in terms of more advanced and hand tying, but also manual dexterity tasks. And what we did with this is we actually then, with our partners at VARS at Monash University, they created software. And we were able then to create a software on the HoloLens where people went through and they actually monitored their hand motions. And you can create this environment. So you can see here, the hand tracking then comes down, you can interact with it. And as we had 34 participants of varying degrees of surgical expertise go through, you can see here, it actually differentiated in terms of the path length, either in the left or the right or total, in terms of the path length of the participants. And what you can see here is that with wearing the HoloLens, with them still operating and doing what they could do, we can actually differentiate their skill level based on something remotely operating and looking at them. So this is the first step. We're now actually putting it into more complex and a simulated operation, and then we'll be going to the actual operating theatre and getting people to wear this while they actually operate to then see whether we can differentiate it. Now, why is that important? It's important because, one, just as I do with laparoscopic surgery, I'm getting an objective marker. So not only am I as a trainer, and I like to think I'm hopefully relatively good at it, I can give them feedback by watching them. I can also, it becomes automated, becomes objective as well, and it can guide self-directed learning for them as well, all by wearing a mixed reality headset. And these things are actually evolving in terms of what we do. And this is another example, because then you think, actually, I can remote, when they're doing an operation, I can then see what they're doing. And this is from Philips, where you can see that they're actually doing a procedure on a patient and having holograms. So I can then see the visual operative field of what they're doing, being in a remote site, and then actually giving them advice, dropping a circle around it, saying, don't cut here. Now I could pop up in the view finder like that. I could say, you need to do more dissection here. You need to do a bit more here. I can project then images of the cross-sectional imaging onto them with a tumor if that's relevant. And that's sort of the next level where you go up and up. And that's where you really get the surgical mentorship into the realm as well. So in terms of that, the next stage is really global health. And I'm going to just start by, why is this important? So the Lancet Commission came out now a few years ago in 2015, and this was a call to arms for surgery. And what it found is that actually there are close to 5 billion people, we think it's more close to 6 now, who have a deficit in their access to adequate surgical care, and 1.7 billion are either children's or adolescents. And so there needs to be a change in focus for global health, from vaccinations, from all those kind of other endeavors that are being done with the WHO to global surgery. But the problem is there's not enough surgeons. So how can this help? And it's also about equity rather than just equality. So you can see here we have equality, but it needs to be equity, where we don't just give them what we have, we actually then tailor it and we give them additional resources or adapted resources to what they need. And this is what we've done with Pivot. So this is, again, following. So we had our national training program. We taught people in each of the states. We thought, why not do this further? You know, if I can teach up in Darwin from Melbourne, I can get objective data. Why not do it to Fiji? So we did a pilot project, which has now been integrated into the curriculum at Fiji National University. And in a couple of months' time, we're launching it in Samoa. So we're going from country to country, launching this. And this, when we did it, we set it up. We had a big Moodle, which we put on, loads of different information there to train. We had the online curriculum metrics tracking, which I showed you. We shipped them out, portable training labs with the eSIMs. There was interactive webinars, evaluation, and faculty development as well. But the thing of this is we never set foot in Fiji. And what we actually did is we trained up 60 general surgery and O&G trainees remotely with this. And now this actually equated in this pilot study to about 90 hours of practice. And they performed about 1,300 tasks on the simulators. And then they submitted about 20 hours of this, which then got direct feedback from us by us watching the videos, giving them targeted feedback, including the metrics from the system to do this. And this was actually 261 tasks. Now, this is not possible without the technology involvement and integration into it to help guide us, to give us objective measures, and to really get things focused and go from there. But we also done it to other places. So this is PNG, our PNG program, where we created a pediatric one. And same thing virtually, creating that sort of virtual environment. You can see us, this is in Melbourne in our centre, and we're connected to PNG. We ship them over everything, we train them up, and they're running workshops to their nurses to train them up to how to deal with a sick child using a simulator there. Now, this was when I couldn't actually leave my house for more than 5 kilometers, but I could go to work, and we could run the workshop from here to PNG using digital training methods and virtual means without actually leaving the country. And we still haven't gone to PNG to meet our colleagues yet, despite running a successful program there. I mean, you kind of go, okay, well, fine, that's great. What a PNG, we've got Fiji, we've got Samoa, we've got other places, but we're also centering on our own areas here. And we're actually going with Bairnsdale, Sale, Traralgon, and Warragul, where we're putting in remote training stations. Now, this is the next level where, and for those who are in IT will know there's been slight differences in the way that we can now access from site to site. But those sites have got our trolleys, we can connect up, get intraoperative images. And the idea is that we help our surgical partners actually in a rural setting in Victoria who are under-resourced. So my general surgical colleagues will give me a call when I'm on call and say, can you just have a look at what I'm looking at? Now, it could be a HoloLens, but it's actually now here where we can get there with the overhead cameras. It can connect to the inbuilt systems in the theatre. And then rather than the patient then having to come all the way to see me in Melbourne and then have another anaesthetic, I can give them advice if possible. And I can actually see what that surgeon is looking at and give them advice remotely. And this could be the next generation where we're doing it then with HoloLenses in really remote settings. Because if you're in the hills near Angao in PNG, which is where we work, and you need a cesarean section, you're not going to survive the transfer from the hills with no proper roads to a centre who may or may not be able to help you. However, if there's someone there who can help you, not ideal, but bear in mind there is a huge deficit in surgical interventions and cares providers that can happen, we could use technology to then do them. And that's what we're investigating, is using things like Starlink and remote satellites to then get internet access for wearable technology to then guide them as they're doing procedures. And you might say, that's crazy, Ram, you're out there. But this has been around for a while. And this is Normandique, who's a French group that we've been in close discussions with. And you can see they're using wearable technology, the HoloLens, and they're actually using it with little battery packs with Wi-Fi integration. So they're actually then using it for first responders. They have a base where they have the doctors and nurses who give them remote assistance. And this could be done not in Paris, but it could be done in a low resource setting. And that's where we're moving towards with our research streams. And everything we're doing with our researching of the HoloLens is to get to this point where a healthcare provider, not necessarily a surgeon, can put on one of these, get in touch with, say, someone like me, who can then advise them. Now, it's not going to be optimal care, but it'll be a lot better than what is achievable. And as Chris was saying, you see remote monitoring, all these things will be integrated in where you're treating the patient actually where they need to be treated in. You're then taking ECGs, you're taking monitoring, you're sending them back to the base and getting expert help. And then these medics actually go through on motorbikes to cut through the traffic so they can get there much faster than they could do otherwise. And it's those kind of things where it's great for our setting. It's great for rural Victoria. It's also great for global health settings wherever you are. And this is going to be the future. Might not be with the HoloLens, might be with but it has to be with wearable technology. And as things get better and better, that's where we're heading towards. So thank you very much for the invite. I'm sure there'll be some questions afterwards, so we'll go through that with the panel. And I'm a bit of a self-confessed geek, and this is when Lord Vader came to our simulation center to give a workshop to a select group of his troops about how he finally defeated Obi-Wan. But thank you very much.
Thank you, Ram. Really disappointed I didn't get an invite to that. Love it, love it. We'll keep moving. Please do use the question and answer function. You can ask Ram questions, you can ask me questions, you can ask anyone questions. Had a couple of answers as we've gone. Now, I think we have Professor Tan Phan online now with us. So I will hand over to Tan to talk to us about his work in the stroke domain.
Thanks, Chris, for inviting me to this talk. It's in fact, to be honest, we started this work many years ago, but when we set it up, we didn't really think about it as a digital twin. It's probably until more recently when you mentioned about digital twin that the idea I start to realize that it is part of a digital twin. So the work is done in collaboration with James Hilton and Matthew Sinnott from James Hilton and Matthew Sinnott from CSIRO, which is now Data 61. So just to give you a quick overview of what we're talking about, the areas in red there that's labeled the circle Willis. And most of us tend to believe that the circle Willis is the conduit to channeling blood to different parts of the brain, so that if you have a blockage from one part, the other part can come to the rescue. But as you can see here, that there are many parts that are actually distal to the circle Willis. And so if you have blockage of those parts, how do we rescue those parts? And we know from clinical work that if we block one of the more distal artery, and the circle Willis is no longer in play, not all of it gets damaged. So there are other what we call collateral system in play that salvage the brain. So essentially what I'm talking about is how do we rescue patients with ischemic stroke. So this is something we have published and something we observe. So this is a patient with a clot involving the middle cerebral artery. And you can see that not all of the middle cerebral artery will get infarcted. So there'll be some part of the middle cerebral artery territory that gets damaged, and some part of it is relatively less likely to be damaged. The same thing happened when the clot involving the more proximal internal carotid artery, which then generate the middle cerebral artery. So again, not all of it will be damaged, as the area in purple have low probability of being injured. And here we have just the internal carotid artery being occluded only, but without the middle cerebral artery being occluded. Again, the area that has high probability of infarction is a lot smaller. So that was the idea behind it, is that what is this second system and how do we measure this second system, or the leptomeningeal anastomosis? So that was the idea behind why we created this computerized model of the cerebral artery. So to start off with, we look at anatomical maps of the brain, and as well as record all the measurement. And these were the hand drawings that we use, including all the numbers and the number for each of the segments. And you can see that they were drawn in a way that you can think of them as pipes within a network. And you can use graph theory to connect these pipes and generate analysis. So this is what they look in a more cleaner way. And then there are areas where the middle cerebral artery connect with other branch from other artery. So those are labeled in yellow. So the plan then is to generate anastomosis to the other blood vessels of different size and perform a sensitivity analysis to see at what size that you have the leptomeningeal leptomeningeal anastomosis that makes those areas salvageable. So that's the original idea. And the method, as I mentioned before, is that we used the anatomical work by Rolton and Van der Eken. Van der Eken described this the anatomy back in the 50s, and more recently it's been updated by Rolton. We connect network pipe, we assume laminar flow, and we arrange in a connectivity matrix. And we set it so that the majority of the blood flow is in the front of the brain, with a quarter of the blood flow in the back of the brain. And then we just use a linear solver to solve the flow in all the branch. Originally, we wrote this in MATLAB, but since then we put the data over to R. So now it sits within R for the analysis. So we then perform a series of experiments assessing the connection between the arteries, varying the size of the blood vessels, and then connection between different territories, and then again vary the size of the blood vessels. And here is the first case where we do not allow for any anastomosis between the artery. And as you can see, when you occlude the internal carotid artery and the middle cerebral artery, there's just no flow. So that's the area in red. And again, if you have just the middle cerebral artery occluded, then the entire territory gets, there's no flow again. And the same happens as you go further and further up. So here now we only vary the interterritorial. So we vary the interterritorial leptomeningeals only by 0.25. And again, it doesn't cause any improvement in flow at all. But now, as we set the interterritorial leptomeningeal anastomosis high up to 2 millimeter, you can see that a majority of the area of the blood vessel, there's salvage from cross flow from the other territories. So in some of the patients, we speculate that the interterritorial anastomosis, if they are present and they are up to 2 millimeter, between 1 to 2 millimeter, then those areas can be salvaged. And here's another way to describe that, where we vary the interterritorial leptomeningeal anastomosis. And as you can see that as we keep increasing it, then you can get quite good salvage. Here, if we vary the intraterritorial leptomeningeal anastomosis, but keep the interterritorial leptomeningeals constant at 2 millimeter. So for what we've noticed from our experiments is that the diameter of the interterritorial leptomeningeal anastomosis has to be more up to 2 millimeter for them to be important. But the intraterritorial leptomeningeal anastomosis are not so important. So we found that this computer modeling provides ability to understand the effect of arterial occlusion on regional blood flow, as well as the rescuing capability of the interterritorial leptomeningeal anastomosis. So we had shown this to an international expert on clot retrieval, and he asked us to look at the possibility of performing to model how we can perform clot retrieval in patients where the carotid artery is occluded on one side, and they need to thread a catheter up the internal carotid artery on the other side. Now, in those situations, as they thread the internal carotid artery up, you get blockage of both carotid artery. Now, he's been in contact with various other people around the world, and they couldn't solve the issue. So he asked if we could evaluate that task within the computerized model of the artery. So these are the experiment conditions that we set up, where we have the right and internal carotid artery occluded, the right internal carotid artery occluded with the left middle cerebral artery occluded, and so on. So we have a series of different experiments. Now I'll just show you an example where there is just the left middle cerebral artery occluded, and then you thread the catheter up the left internal carotid. Here we simulate that by causing progressive stenosis of the left internal carotid artery. And that you can see in the number where it goes 0.25, 0.5, 0.75, 0.9, and so on as we go up. So here, as you go up on that side, and you go up from 0%, 90%, and 100%, it doesn't truly affect the blood flow on the left side. So in that setting, it's relatively safe to perform a thrombectomy, as it would not change the blood flow. Here's a different situation where now you have the left middle cerebral artery occluded and the right internal carotid artery occluded. So the left side and the right side are occluded. And you're threading a catheter up the left side. What happened to the blood flow? As you can see here, in a case of a classical cervical willis, again, it doesn't actually change things very much. But things start to change as if there is a communication in the anterior circulation, which is the anterior communicating artery is absent, in which case there is some decrease in blood flow involving the left anterior cerebral artery territory. And that happens because normally in these patients, you get blood flow coming from the back of the brain coming up to provide rescue. So we also, in this setting, we show certain conditions where things may not work according to plan when it's not the classical situation. We can also simulate what happened when you perform a carotid endarterectomy. Again, when you perform a carotid endarterectomy, you need to clamp the carotid artery and then open it up and clean it. In that setting, virtually it's the same as causing a stroke because you block the blood flow in that artery. So when you have a classical cervical willis and you perform carotid endarterectomy, here we show that nothing happens to cerebral blood flow. Even when there's a missing anterior communicating artery, again, when you block that artery, there's also no problem. But when you have a situation where it's not a classical cervical willis and the anterior circulation and the posterior circulation of the brain are not connected, then when you claim, because you've occluded the left and occluded already the right, then you have a situation where there's zero blood flow to the brain. And so that's a potentially unsafe situation to operate. We've also applied to other aspects of blockage of the brain to the anterior cerebral artery, which is a different branch of the internal carotid artery. And here we show that if there is occlusion of the anterior cerebral artery up to the level of the anterior communicating artery, then you get dramatic decrease in blood flow. Again, that's quite easy to explain because of the ACOM is part of the cervical willis. So hopefully I've shown you the model of computerized model of the brain, which is based on a graphical network. It's not a physical model because of the difficulties with creating leptomeningeal anastomosis. It has corrected anatomy, but not geometry of the brain. But to perform a corrected anatomy and geometry model would need quite significant investment to segment and label the arteries, at least down to the fifth order branches. Thank you for listening, and we were supported by a grant from Monash University and CSO to perform this task.
Thank you, Tam, very much. Thank you. That's very interesting because I'd obviously seen the model online, but having the interpretation usage explained was very valuable. We've got a couple of minutes, Tam, so a question for you. Obviously, some of that work started quite a while ago, but you've also published fairly recently. Do you have examples where either in your general approach to a situation or the management of a specific patient, you've done something different informed by that model?
I've used it I use it to teach our trainees and how to frame, how to make decisions on, thrombectomy and as well as carotid endarterectomy. So we've used it in that setting. So yes. It's not to the high end that, that RAM has, because this is a bit more basic in many ways.
But I think that's very impressive because there's a mixed audience. Some people in the audience may not quite appreciate that you're literally talking about, in some of those clinical situations, the difference between people living or dying or surviving with a huge morbidity burden or walking again. So very big decisions that, you know, in some ways your approach to those problems is being formed by this digital twin. I think that's really impressive. So don't worry about the sexy factor. That's impact is really big. That's good. I think it's wonderful.
Thank you.
I see Andrew actually was answering a question then about privacy and governance of the data that makes up the twin. We might come back to that in the discussion as something I wanted to add to there. But at this stage, I'll hand over to our next speaker, who's Dr. Andrew Stevens. Thank you, Andrew.
Excellent. Thank you. Okay. So this work's a little more preliminary compared to some of the other works presented today. Quite early days, but anyway, let's get on with it. By way of background, our lab is an engineering lab located at the Victorian Heart Hospital, and our work primarily focuses on mechanical cardiorespiratory support devices, but we also work on cardiac emergency medicine as well. So we bring together multiple disciplines of engineering and medicine to solve critical care problems, and we primarily do that through new devices, experimentation, computer simulations, and also AI. Now, one of the systems we work on is ECMO, which is an artificial heart and lung therapy. Basically, it's this little thing here. And what happens is you get two tubes connected to the body. One draws the oxygenated blood out of the veins, and the other one pumps it back into the body after it's been oxygenated externally. And so this little system here functions as the heart and lungs, and it's typically used as a short-term support to bridge patients to transplant. Many patients are also put on ECMO to recovery, so it rests the heart and lungs until the patients recover themselves. And it can also be used to bridge the patient to a long-term artificial heart or something similar like that. Typically, ECMO is used for about 7 to 60 days, but it's an extremely expensive and complex therapy, and it's used to treat a wide variety of patient diseases. And because of the risks associated with ECMO, it's only used as a last resort, and as such, it's considered a low volume therapy, meaning doctors don't have a chance to perform and practice it regularly. And in turn, this leads to problems with training and skills retention. And so this is what we're going to be tackling here. Another issue in the current training is that ECMO training is not standardized, with each hospital being in charge of its own training programs. And because the training curriculum is not standardized, there's no formal credentialing process either. Finally, because ECMO is such a complex therapy, it requires a really wide range of macro and micro skills. And these skills include things like implanting the device and then managing the patient on it for, several weeks to several months, recognizing and treating complications, as well as more sort of soft skills like coordinating a large team of ECMO providers. So our lab is working on a variety of tools that can help to facilitate this training, and some of the tools are similar to the ones that have been presented already today. So one arm of our research is these hardware simulators. Basically, you've got these little vessels that are made, and then we use a tissue mimicking material which has the same mechanical properties as skin. That's then embedded into a mannequin, and the mannequin has a full cardiovascular simulator inside it, which allows it to pulse, change the blood pressure, create blood flow, and even change the color of the ink running through it. And then we drape the whole mannequin and we're able to run simulation-based training exercises with it. So these physical simulators allow for individuals to learn skills, but they can also be used for team training exercises as well. And this is currently how they're training new staff at the Alfred Hospital, which is where we first rolled it out. So what we'll be focusing on more today, though, is the software arm of our training tools. So this is for on-screen and also for virtual reality. And the idea of the tool is to have a safe virtual environment filled with scenarios that have been written by intensive care educators. People can then take this package and go away and learn about the recognition and treatment of different complications or changes in patient state while they're on ECMO. So the tool we're developing uses a fully fleshed out cardiovascular simulator under the hood, which results in automatic changes in hemodynamics as interventions are made. So changing the pump speed or changing the types of drug infusions that the patients are on automatically updates the monitor and the patient states. And we also have planned to have the environment have a built-in examination system. So this is the idea behind this, is that the examiner acts as a sim master and they can cause changes in the patient's state, and then multiple examinees have to identify and rectify these changes. So we can see this software can effectively solve many of the problems that we have already discussed. It allows clinicians to learn and practice ECMO skills between clinical cases while also reducing costly animal training, which is the current gold standard. The system allows for a standardized ECMO training curriculum to be developed, and this in turn will allow for standardized credentialing, including real-time examination and pain point tracking. And also the software can be used to treat a range of micro and macro skills by designing scenarios around specific learning objectives. So particularly for the VR version, we're looking at including team-based sims, which if done right could be used to teach team-based skills even remotely, as we saw with the surgical trainers a little while ago. So looking at the implementation of the software, the cardiovascular simulator is built on an open source system called Kitware Pulse, which is actually quite sophisticated and includes things like metabolic demand and renal function, nervous and endocrine systems, cardiorespiratory systems, as well as drug infusions. And as you can see, we've created various assets which sit on top of the software and simulate the ICU pod. So this is kind of the digital twin whereby you can set this cardiovascular simulator up to simulate different patients that exist in the real world. So our ICU environment includes things like the patient monitor, which streams data directly from the simulation, the ECMO console, the gases that are associated with ECMO, the infusions, the ventilator, and of course, interactions with the patients. And each of these sort of interactable elements have a series of actions that are assigned to them. And these actions are based on the actions that clinicians will do to sort of intervene. And so as actions are implemented, they make direct changes on the cardiovascular simulator to provide real-time feedback on what's happening with the patient. So each of our learning objectives has been designed by a team of clinician educators or clinical education researchers, and each learning objective is delivered by a scenario. So scenarios consist of a series of actions, including correct actions and also actions that are incorrect, although they may be seemingly correct to newcomers. We also have included things like observations and occasionally multiple choice questions. And then to really sort of frame and build up the simulation environment, we've developed, or we're in the process of developing, 2 characters which serve to set up the scenarios and prompt and make suggestions to the players, but also serve as devil's advocate and occasionally provide red herrings in there to try and trick the player. So here we have the professor, who's a bit more senior and usually tries to prompt the player, but also questions the player's actions and challenges them to sort of think and justify why they did or why they made that action. And we also have a series of bedside nurses, and their role is primarily as well to prompt the player, but also to give situational information. These bedside nurses will also make suggestions, some of which are conducive and some of which are not conducive to the learning objective. So sort of being served up by these characters is a multi-tiered hint system. So at first it lays out the basic scenario, then gives an observational prompt. And as the player keeps asking for more and more hints, it finally leads the player to the correct action. So the idea behind these is that the hints can be turned on and off for examination. And eventually, rather than being on a little clipboard, they'll be served up by the characters. And finally, we're working on a framework to convert text written by the clinical educators into a coded scenario. So this is done using an agreed upon language and format between the coders and the educators. And this will allow us to farm out the scenario writing to multiple clinical educators and build our library very quickly based on the available actions that we have available. So we're beginning a rollout of this product locally. We're hoping to start with the Victorian ECMO service, which is a body built to standardise ECMO training procedures in Victoria. And we're also looking to work with interstate consortia of a similar sort of nature. We've thought about how we could commercialize this, and one idea that comes to mind is working with textbook publishers who could help to adapt and maintain the tools. And the type of business model that they could operate would be a subscription-based fee, which would allow a steady stream of income and also allow the publisher to continue debugging and updating as clinical practice changes, and of course, adding to the content and functions. As researchers, we've developed a couple of research projects around this tool. Firstly, we've designed a trial to see if there's a positive effect on learning outcomes from using our ECMO training software. And in this, we've designed as a crossover trial because all of our sites want the intervention, but we don't have enough time and resources to do a step wedge trial at the moment. We can see how the crossover plays on the left. So Group A will get the screen-based learning, while Group B will get the traditional classroom learning. They'll both go through a curriculum of 8 to 12 weeks. We'll then take some outcomes measurements based on the learning that they've done. So these would include things like time to decision making, time to reaching a solution, number of mistakes, self-assessments, and assessor grades. Once they've had the outcomes measured, there'll be an extended period with no learning, and then the crossover will occur. So Group A will get the classroom learning and Group B will get the software. We'll measure the results again. So obviously, limitation of this study is that the aliasing will be there, which is the knowledge that they will gain before the crossover. But there are sort of some really good statistical methods that we can use to help and deal with that as well. The other trial that we've designed focuses on gamification of the tool and how it helps learning outcomes in the ICU. So in this one, we've just got a randomized trial where different centers will be placed in the gaming and non-gaming arm. The gamification that we're looking at for this trial are things like ranks, so A, B, C, D, and based on that would be based on the sort of observation decision time, the number of mistakes they made, and the number of hints used. We're also looking at levels and gated progression. So the idea there would be, you start with an easy level, then you go on to a medium, hard, and finally boss level. And we're finally looking at leaderboards as well within institutions, but we have to be a bit careful about that because it could be more harmful than useful. So each of the arms will go through the 10 to 12 weeks of learning in the gamified or non-gamified, and then there'll be an examination and outcomes measure. And we'll be looking at some of the outcomes that we had in the previous study and potentially using a standardized final exam. But we're also really interested in user acceptance and engagement, and whether the gamification makes the education better, or if the participants just felt it was a bit silly and or annoying. So those are the studies that we're thinking of. Now, I'm going to give a brief live demo of our software. Just keep in mind, it's a very early build. It's just what we're presenting today is just the latest stable build. There are quite a few textures missing, and many of the actions and scenarios still need to be programmed in. But as we expand and get our 4K textures in and our ray tracing on it, it's going to look much more polished. So hopefully you can see my screen here, and I'll just walk you through what we've got. So here's our patient that we can see here. We've got the ECMO console, which is interactable, and also the gases, which lead into the ECMO. This is a little computer that we've brought in, which is going to contain situational information about the patient. So things like clinical history, previous blood gas draws, and things like that. We have our data monitor, which is streaming from the simulation. Ignore the blood gas, ignore the blood pressure line there. That's not the right waveform. We also have the infusion pumps to deliver the drugs, and you can sort of turn these pumps up and down, and the appropriate drugs will be administered in the streaming software, and that will change what's going on with the patient. We also have the ventilator, which will be streaming data in a similar fashion to the vitals monitor. And those are most of the interactable components that we have at the moment. So each of these has actions associated with them. So starting off, we're looking at the first scenario, and this scenario is called access insufficiency. So access insufficiency occurs when the ECMO console, which you can see here, draws more blood out of the patient than what the patient has. And this essentially causes the vessel to collapse around the cannula and causes this kicking motion that you can see here. So this is the deoxygenated blood coming out. It's darker, and the oxygenated blood coming in. So we get our nurse calls us over and asks us to review a sudden onset of hypoxia in the patient on VV ECMO. And we can ask for more and more hints. And so the first thing we want to go is over to the console and see what's going on. So one of the key mistakes that many clinicians make is that they try to turn up the ECMO speed to try and increase the flows. And when we try to do that, we get a warning saying that this is actually not the right thing to do. And so we go back and we turn down the ECMO flow, and there'll be some little text here that says, congratulations, this was the correct thing to do. So then going back, we need to see what changes have been made to the patient. So this step is really about making an action and then learning to observe the patient. So we have things like, checking the patient, making sure that their hands are warm, their feet are pink. We can go over and check the notes. We can check the monitor, the infusions, everything's okay here. The ventilator, the console itself, and also the gases. And then once we've made all of those checks, we can move on to the next stage. So this is the end of the scenario. It's a reasonably short scenario. And the nurse comes up and prompts us, I'm glad we're more stable now, but we're still a bit hypoxic. What do we do? So there are three incorrect choices here, which are these three, and picking each one provides an explanation as to why it's the wrong choice, and also it's noted that the wrong action was selected in the background, and then picking the right one should be in a different color and little fireworks should come up, but it basically says, look, this patient, their patient state is fine, we don't need to do anything. And then we get booted back out to the overview screen. So that's just a brief demo of the simulation that we've been building. It's rather remarkable given that it's all been done basically by a single developer. So hopefully with a bit more time and manpower, we'll be able to really get that looking very good. In conclusion, we're developing a new simulation trainer for artificial heart and lung therapy. We're leveraging clinical education experts to help us to build and design this to make it the best possible education system that we can have. We're developing this to be an expandable and scalable system. And of course, we have many features planned on the horizon. This tool could be the first of its kind, which offers a solution for standardized training and credentialing of ECMO in Australia. And if we execute it well, it really could emerge as a global front runner for ECMO training. The platform, of course, also has utility for education research and expansion into other areas of medical training, such as general ICU. So this is our quite extensive team. These are the guys that are currently working on it now, and a special shout out to Derek, our lead developer. And we've also got a range of other collaborators who are working peripherally on this as well. So many thanks, and these are my details for those who are interested.
Thank you, Andrew. Again, wonderful to see what I get glimpses of all pulled together. Wonderful, really good stuff. I'm just looking at questions at the minute. So we don't have any pending questions in the Q&A. So I really would encourage people to pop some questions in. There's been some really interesting topics covered today. So I'm sure you have thoughts. Comments are also welcome. I will point our speakers to a question in particular. There was one from Xiao, which I've had a go at answering. It's more in the mental health space. One from Nigel, which we could all probably have a go at answering. I'll just add my 2 cents worth there, and others can comment in the background before we go on to other questions. So Nigel's asked a very good question about the governance and privacy issues around the data used in digital twins. And I guess there's a range of paradigms being presented today. Probably the one that's a bit different is the virtual autopsy one, because it's actually generated off real patient data. As I sort of alluded to in my talk there is a strong precedent, a strong ethical framework, a strong research governance framework around that. And still a fair way from that then going into a real world usage. So it's very much an R&D activity at the minute, but it's an really interesting question for Nigel to ask when we start to do things like Tan sort of alluded to, where you might take insights in a model generated from lots of people's data and then add that to the treatment of a patient and add their data into that environment. Some interesting things come up. If I flip topics a minute, this is one of the really interesting things around ChatGPT at the minute. So it started to cause quite a stir in the medical world, not because it can generate outputs, because we still expect senior clinical staff to validate those outputs, but in getting your outputs, you need to and sometimes add individual patient data, and that's a big problem. You don't really know who you're giving it to. You don't really have guarantees about what else they might do with it. So a good question, the kind of issue we're constantly watching in our environment. I'm just conscious here too, we've got some questions. So there's one directly for you, Andrew, from Justin. Perhaps if you could talk to that, just as easy.
Yes, definitely. We would like to expand our simulation beyond ECMO. As I said, the cardiovascular simulator that we built it on is all open source, which means that it has a lot of stuff in it that's being contributed by a lot of different people. The sticking point will be just resources and manpower. And you know, if you want to get together some money with us and build one for neurovascular, sounds like a great idea.
I think that's one of the things that struck me just then, Andrew, reflecting on Kabir's work and this sort of non-touch environment, seeing how all of the ICU environments starting to come together in your ECMO one. There's a lot of reusability there. Really interesting stuff. Really pleased to be a part of it. And as we discussed before the meeting, wonderful, we've got Derek for another year. We would happily welcome co-funding partners in this work, because we want to keep going and we want to keep some good people involved in the project. Ram's going to have a go on that one. Did you want to talk to that, Ram, the AI one, or are you still typing?
Yeah, no, I pressed the wrong button, which is not very good on the technological webinar. It was meant to start typing. But no, I guess in answer to that, I think AI is already being used in this space. And I think that, yes, it definitely will be. And I think it can probably, say for my world of remote surgical training, will overtake a expert person. So I think that will all become automated. And I think that the expert surgeon will then just be required for the really fine tuning of things. So I think an AI can probably take you up to a certain level. It'll be an interesting phenomenon, I think, because as someone who trains the next generation of surgical educators, if they're not going through and assessing those kind of assessments and only then doing the top level, then their learning curve is gone. So if AI does take that away, it's going to be an interesting paradigm where you're kind of asking them to do the high-end assessments, but they haven't gone through the learning journey of the more basic ones and done that learning cycle. So, but I think that AI is going to be much better than I could be at looking at it, and probably a lot faster too. So I think that it will be the future, and we just have to adapt to it.
I'll speak against that sentiment, Ram. I think it's a long time before AI is going to be better than you. But there's a trajectory, no doubt, no doubt. Tan or Andrew, did you want to comment on that question about, you know, what do you see happening with AI, maybe with your particular projects in mind, or more generally on the topic of digital twins?
Andrew, did you want to take that up first, or?
Yeah, I can comment. I do a little bit of work in AI, and it's coming, and there's nothing you can do to stop it. That's my sentiment. And you know, it's going to proliferate all aspects of research and work. I've noticed that I've seen recently they're hiring people at large businesses who are professional ChatGPT prompters, because they can cut, you know, they can cut together code that 4 or 5 junior developers could do just through ChatGPT and a little bit of foundational knowledge. So I don't see any reason why it wouldn't come to this, to digital twins. And the leap is so logical too.
I mean, for me as a clinician, I see AI. I hope that it'll be the future very soon, and it can reduce the training of, you know, maybe we just need Dr. Spock and how a thing of the patient, and you know, don't have medical degrees anymore, because I think it's overrated. Doctors.
No, I mean, I think that,
no, I'm being serious actually.
I don't think so, personally, but you know, I'm just a humble engineer, so maybe I'm worried about other engineers being my doctors.
There's a paraphrase that people have used in medicine, and it's going around a few professions, and I think this is true. You know, it says doctors won't be replaced by AI, but doctors who use AI will replace doctors who don't use AI. That's a bit kitsch, but it's probably not far from the mark. It's interesting, you know, that there is this sentiment, Andrew, of it's coming and we can't stop it. But there's certain places we need to be really careful. And it was really interesting. I posted this on social media. I think maybe Sunday news broke of a major health service in WA from memory, came out and locally banned the use of ChatGPT on the basis of at least one of their medical practitioners generating clinical documentation out of ChatGPT. And again, it's that issue of, it's not so much what came out, it's like, who have you just given patients data to? And you weren't really supposed to do that. Some of that stuff is got around by, can we build big enough large language models that sit within a corporate boundary that would get away from that problem? Then it's, you know, technology you're hosting, but it's interesting times. And I agree with the sentiment that it's going to come to digital twins. I think that's probably where the real value kicks in, where you can postulate certain outcomes of treatment based on an artificial intelligence model, and you can also display it in visually meaningful ways to guide decisions. There's just, yes, Peter McDonald has made a Terminator reference, which is not far off the mark. Sarah Connor is worried. If you don't know what that means, it's probably out of the scope of our chat to but yeah, we are all thinking about the good and the bad that can come. Now, Ram, I was going to ask you, and a welcome comment on everyone, but I'll start with Ram. You know, I haven't worked in aviation, Ram, or in construction with large machinery, but I think the common sentiment is they have been very good for a very long time in how they train people. They've been training them in artificial environments for decades. And it's just what you do. You don't skip around that. And yet your statement is buried in my brain. See one, do one, teach one. It's the same paradigm I was trained in clinically in the late 80s and early 90s. A bit of me thinks it's probably still the case in many hospital wards today. Why is that? Why, you know, we've got human life at stake. Why have we not latched onto that paradigm, that way of thinking about training until more recently?
Oh, it's a great question, and I think that it's interesting where there's resistance. So the same resistance we see sometimes with AI at the moment is the same that we've had for surgical sim. I remember the study I showed from 20 years ago got rejected at an editorial level when we submitted it for publication, with an editor just writing back saying there's no place for this, surgeons train in the operating room, and just threw it out. So we've come a long way, Chris, I think in the last 20 years, and I think there's more to happen. I think that there is an acceptance now that competency is more important. I think that but that change took, for want of a better word, the retiring of a certain generation to then go. And I think that certainly was the roadblocks that then got cleared. But I think there's also a higher expectation. I think there's greater monitoring. I think that patients are much, and understandably so, are more in tune of what should happen and how it should happen. And that's great. And I welcome that. And I think we need to be more transparent about things. But there's also an accessibility issue, and I think that just the other aspect to see one, do one, teach one is the working time directive. So which has come out universally, where we don't work 100-hour weeks anymore in surgical training, which meant that we've had to increase the amount of surgical trainees, which means that generally speaking, we have to find alternative ways to train them. So I think that has also been a way that the paradigm's changed, and the fact that we just can't train everyone the same that we did. But there are, I guess, with anything, there are still the slow adopters, and there are some still slow adopters out there, and the change is coming. But I think that also as technology and gets more sophisticated and the evidence base is building, you can't stand against it. So we know that it's not everything, but the evidence base for picking up laparoscopic skills, say on a bench trainer, is now so well researched and so well evidenced that people can't, argue against it anymore.
Yeah. Thank you. And Dan, I'll ask you the same question from a physician training perspective, but just to set the scene for everybody, Tan and Ram are both senior specialists. Ram's a surgeon and Tan's what we call a physician. Doesn't do surgery, but does interventions of other kinds. And they're very different worlds in medicine. But Tan, what about training physicians and interventionalists in your world? Do you see increasing role for technology? Is it still lagging? What do you think is going to happen?
I think you're talking about clot retrieval, and there are some models now for people to train that. I think I just saw that just a minute ago, there was a question from Justin Moore, who's the head of neurosurgery, to Andrew, and I think he's alluding to a more digital version of that. I think the difference with from back to where you put a catheter up to the brain and pull the clot out is that you need to feel the resistance. So it's not just looking at the blood vessel anatomy and the effect of blocking and stimulate a clot and then its effect on blood flow. So when you want to train someone, you also want to give that resistance in certain part. Because otherwise, if they think that it's the same feeling all the way up to the brain, they might puncture the vessel on the way up. So, and maybe Ram could explain with his model, is there different sensation when they perform the surgery?
You mean, so that's a good, you mean in terms of laparoscopic surgery?
Yeah, or any forms, surgical simulation that you provide.
Yeah, and I think that's a great question. And I think that there is a huge avenue of surgical sim for virtual simulations, so lap sim and things like that, where you have virtual operating and then you're operating on a station. And there's two reasons why I haven't adopted it. The first is, as you say, it's about the actual haptic feedback. So we know that haptic feedback is changed with laparoscopic surgery anyway. But when you're doing it in a bench trainer, when you're doing it with a bench trainer, you're still getting a feel because you're interacting with the tissue, even if it's synthetic tissue in the trainer. So you're getting an idea, you're tying the knot too hard, so it breaks. Or you're grabbing tissue too much so it rips, or like my glove model, you use too much force and then the latex rips, so you know that you've used too much. Whereas in the virtual space, it doesn't. And yes, there's vibration. Yes, there's clever things that they can do, but it doesn't recreate it. So that's why I've basically used bench trainers and those ESMs that I showed you, the briefcases, because you still get all of that and you're picking up those skills as well. The other reason I do it is that the LapSim, which is one of the most widely commercially available virtual reality laparoscopic trainers, is worth $200,000. The ESMs are worth $2,000. So, which one are you going to have? Thousands of one of them, or just one which sits in the corner? And I used it at my previous institution in London, and the insurance of getting people training on that was very difficult. When you've got trainers, people just training on a bench trainer, that's still expensive. I mean, $2,000 is still $2,000, but they can just hammer it, and then you just can replace bits of it. So I think those are the two avenues. So I think for you, and it'd be the same as you're describing for putting a clot out, you need to have that realization. Otherwise, what you're training is people to do it too soft or too hard, and then you're actually potentially making them dangerous in the actual clinical setting, which is the worst thing you could do in a sim setting.
Actually, if I may weigh in on that, as I mentioned in our talk, I think there's a role for hybridization of that as well. So we had a whole PhD student working on developing the benchtop models. And all they did, they were a materials and engineer, and all they did was they got, various skin samples, measured the forces, measured the friction, the cutting, and then they created a synthetic material which had exactly the same replication. So you get to the skin and then you get to the vessel and you feel that pop when you're doing the Seldinger technique, for example. So I think there's definitely some room there in the hybrid space.
It's obviously, competency and safety is the aim. We need a multifaceted approach, but I suppose one of the advantages of digital is it can be broken down to subscription per usage, potentially for some of these things, which is interesting, but it's not complete training in of itself. And as Ram and Tan are alluding to, patients aren't patients, and people's tissue resistance and how hard you need to push on certain things does vary with different people, and it's very hard to mimic that. One of the interesting things in our work with the Institute of Forensic Medicine is restoration of normality, and how do you make statements about instruments that caused an injury or forces that caused an injury. And they've traditionally worked in that sort of, tissue substitute ballistics gel kind of world, and it's fraught, especially when you then try and take it to court and show a repeated pattern that you can trust. So it's a really interesting, unique space for opportunities around that stuff as well. I note a comment from our colleague Irwin that the university IT department, which is quite massive, All These Solutions, is actually putting together some AI capability, and I'm sure part of that is understanding what's about at Monash, which is good. It's one of the advantages of a place like Monash, which is so large. I don't see any other questions. I might just mark time for a minute or two in case any other questions come in from our participants. What I'm really hoping from today is you got to see a really diverse range of initiatives and activities that fall under this broad banner of digital twins. And the digital twins can look like lots of different things with lots of different presentations, if you like, different levels of digital maturity, combinations with physical environments, as Ram has shown us as well. But also just to make a statement about working with us at Monash. We have huge amount of capability in different areas, all sorts of people interested in similar topics. So we welcome approaches from people in the community, from industry, from other partners. And that is part of the function of these sessions, which we deliberately open up internationally as well. And there's no restriction on attendance. I cannot see any other questions come through, and that's okay. I think given that being the case, I'd just like everybody, I think you can only raise a hand. We don't even have a virtual clap. I usually like to get an actual audible clap, but the nature of the webinar means we can't. I'm sure everybody is clapping us right now, so thank you very much. Thanks for your attendance, everybody. Thank you to Andrew, to Ram, and to Tan for your time today and for your insights and your expertise. It's very much appreciated. And I would also like to thank our fantastic FIT marketing and events team from behind the scenes. So Heather and Keshan, Victoria, and many others. And what usually happens with these sessions is after some editing, in a week or two, they should be available on our website. And attendees have also have that flag with them directly as well. So you can revisit it or share it with others. So with that, I'll say thank you very much again to everybody who's helped, and thank you again to our speakers, and I hope everyone has a good night.